My name is Professor Sister Eugenia Amporfu. I studied in Canada. I did my undergraduate in St. Francis Xavier University in Antigonish, Nova Scotia, Canada. And after that, I went to Victoria in British Columbia, also in Canada, to do my master's, also in economics. And then I went to Burnaby, British Columbia, also in Canada, to do my PhD. Victoria is University of Victoria, and the Burnaby one is Simon Fraser University, is in Burnaby. So when I finished, I came to Ghana in 2006 to start teaching here at Kwame Nkrumah University of Science and Technology in the Department of Economics. So I've been at KNUST for about 16 years now. Yeah, I've been here long enough. And I would say I'm enjoying it here, and I'm glad I've come back. Ghana and Canada are different. So you cannot come from Canada to Ghana expecting Canada to be in Ghana. Yeah, but the transition wasn't like that smooth. You know, coming here, I expected to have my own office. And in fact, I asked them if I'll have my own office in the department, and if there will be a phone in the office, and there will be internet in the office as well. They said, yes, 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 everything will be there, so come. When I came, I got my own office, as they said, but then there was no phone in the office, and there was no internet. So to be able to access the internet, something that I had gotten used to in Canada, I could do that from the house. I had to travel from here to Adum, to the central city, the center of the city, to access internet. Then after some time, I found out that, okay, they have it they call them communication centers. So I could go to communication centers to access internet. So it took about a year before we could finally get internet in the offices of the department. And that was challenging for me. And the teaching too, the teaching load was much heavier than I was used to in Canada, because in Canada, when I finished, I taught for 2 years at Bishop's University in Quebec. And the teaching load here was quite heavy. And so it was very challenging. You know, the first year I came, I taught not the first year, but first years at the MPhil level. Well, the class size was okay. It was less than 20, you know, so that was good. I taught microeconomics, and I also taught health economics. But then I taught final year students econometrics. That's where the challenge was. Like the first year, the class size was 175. I thought that was huge. The second year, you know, I complained the first year, but the second year, the number increased to 225, so I stopped complaining. I realized that was normal, you know. And another thing that I had to get used to when I came in Ghana, that was during the Dumso era. So in the middle of this, the lights would go off. It was very challenging, you know. It was really challenging. In the midst of this, I had to also remind myself that I had to publish. You know, I had to publish. And so I would go through all these trouble and make sure that I find a communication center to be able to search for literature and all that. And I made sure that I was also active in attending conferences to do networking, you know, because I didn't want to just come and stay here and complain, you know. So given the environment, what is the best I can do? And that was basically what I tried to do here. My area of research is health economics. And I've done quite a lot in terms of projects and in terms of research. Yeah, when I came, I wasn't familiar with the health economics situation in Ghana, health care provision in Ghana, and even health economics was new in Africa. So there were a lot of workshops for training and that kind of thing. I was very, very active in it. So I was traveling a lot within Africa and sometimes with outside as well. And that helped me a lot. And so I started working on women's health. And then that was also the time that the National Health Insurance scheme in Ghana had been introduced. So I did a lot of work on the National Health Insurance scheme, equity in the premium that is charged, equity in the quality of care that is provided to Ghanaians, the members, NHIS members, the efficiency of the payment scheme that is used by the to pay healthcare providers or the health facilities that provide healthcare to NHIS members. So I examined a lot of these issues, and NHIS also invited me to a lot of their fora, open fora for discussions, especially when they were introducing the capitation. Yeah, there were a lot of discussions, so I was also invited to a lot of them. The NHIS organized this review. There was a technical review of the whole scheme, so I was also invited to be part of it. Not the technical team, the original team, but the subcommittees, and I focused mainly on strategic purchasing. And that area is an area of interest because I focused a lot on the services that are being provided or what is being provided, how do you pay for it, and how do you also evaluate what has been paid for. So it's like what you buy, how you buy it, and then how much you pay for it too. That is also included. The National Health Insurance was introduced in 2003. I think it was actually implemented in 2005. Since then, since 2008 onwards, it's always been making huge debts, and the debt has been accumulating over time. So the financial sustainability of the scheme becomes an issue. And a good part of the expenditure of the scheme is on payment of claims, that is to healthcare providers. So the provision of healthcare is such that there's so much asymmetric information. You don't see what the doctor is doing in the hospital. Of course, the insurance is over there, the doctor is over here. We don't see much information. And the doctors, or I don't want to use the word doctor, but health facilities can provide the care in a way that is contrary to what has been agreed on. Whenever there is the incentive for them to over-provide, as long as that will bring them more money, they will do it. And when there is incentive for them to under-provide, depending on the payment scheme, they will also do it. And it's been like that throughout. And so the big issue now is how do you come up with a payment scheme that will motivate the healthcare providers to provide what is socially efficient? I would say National Health Insurance has made a lot of efforts. For example, they have introduced this a call center for members, NHIS members, to call the NHIA whenever they have problems. Like, we are even talking about co-payment. They are not supposed to pay for services that are covered by NHIS, but they go and they are charged, And do they call? No. Why don't they call? We don't know. So there's a need for more research in the area. We need to make the consumer more active, because ultimately it's the consumer that is the principal agent here. Yeah, because it's a public institution, so the consumer is the owner. So the consumer has to be more active. It is the consumer's resources that are being used to provide all these services. Consumer needs to be more active to ensure that the resources that are available are used efficiently, so that this scheme will be sustainable. Yeah, so there is this huge thing there. And of course, I can't overlook COVID. Yeah, COVID-19 also came and had a toll on the resources. How services were provided because of the emergency of the case. You had to go beyond, certain measures that you have made. And so there's the time for us to sit now and examine how well we did, how should we perform in the future should something like this happen again. So that is also urgent and is also needed. We organized a kind of policy dialogue with National Health Insurance and the Ministry of Health on COVID and on strategic purchasing, how they are getting the providers to do what they're supposed to do. And it was very rich. It was a very rich dialogue. I have this partnership with, I formed a team with some of our members in my department and some in public health department. And we do some strategic purchasing work with SPARC. We call them SPARC, Strategic Purchasing Africa. This is very important to ensure sustainability. It's important because Ghanaians need healthcare, and we need to achieve universal health coverage in accordance with the SDGs. And the National Health Insurance is the way to achieve universal health coverage in Ghana. Yes, and I think that if we work hard at it, we'll be able to get there. Yeah. Recently, there was this Lancet Global Health, and they looked at financing primary health care. Yeah, they looked globally at different countries, and they selected a number of countries, more than 10 countries, to look at different issues of primary health care provision in those countries. Ghana is one of such countries. And I was asked I worked with a group to talk about the capitation as a method of payment in Ghana that was used. We evaluated it, and we were able to come up with a lot of lessons that can be learned by many countries in Africa and in the world too, because capitation as a method of payment is being looked at, examined by many countries now. And Ghana made a bold step in 2012. But we had to, drop it in 2016. There were so many problems, 2017. So hopefully, if you're able to learn this, we may come back again and do it in a better way. And other countries could also read and then also make the necessary changes in their own policies. Yeah, so that was done with the Lancet group, and these are people from all over the world. I also mentioned that I've also done some work with African AERC, African Economic Research Consortium. This is a consortium of economists. They train, is capacity building, so they train economists all over Africa. And they do that by providing MPhil courses and PhD courses to MPhil and PhD candidates in universities all over Africa. So they organize them once a year in Nairobi or some other country. And they invite experts from all over the world to go and teach them. So I've been working with AERC for some time. Now I've been teaching health economics at the MPhil level and also at the PhD level. So that is AERC. And I have also done some work with, national NTA, National Transfer Accounts. National Transfer Account examines what we call the demographic dividends. What happens to the welfare of the people as the fertility rate of the population changes? As it goes down, how do we benefit? How can we take advantage of this to harness and benefit the population? We did the work for Ghana, and we have trained experts in Sierra Leone and the Gambia to be able to also do that for those countries as well. And currently, I am in touch with Sierra Leone again. Now they want to go a bit further. We are in touch with them as well. So that has really helped these countries to be able to do so much. So if you're endowed and you don't share your endowment, you don't maximize the benefits of your endowment. So I would really encourage all those in diaspora to give themselves the opportunity to come here and share, and they will not regret. No, they let them try it and see if they will regret. They will never regret it. So they should come.